Hello everyone and welcome to another recorded lecture of Anatomy and Physiology 1 online. Today we'll discuss Chapter 9, which is on joints. And joints are critical for the function and structure of the human body. Joints link all the bones of our skeletal system to permit effective movement. And not only that, joints also help protect our softer organs. Take our spinal cord, for example. Our spinal cord is protected by the vertebral column. But the vertebral column is made up of joints that are not so movable, right? They're slightly movable. So joints not only have a movement and connection function, but also a protective function. Joint anatomy and joint movements will provide a foundation for the study of muscle actions that will come in subsequent chapters. Arthrology is the science of joint structure, function, and dysfunction. And kinesiology is the study of musculoskeletal movements. And kinesiology is a branch of biomechanics. So it deals with a broad variety of movements and mechanical processes that allow muscles and bones to work together in order to coordinate movement. Since joints are all animated for the most part, some stay still, but many joints are animated and they move. I think it's very important to watch many animations. So I think it's best to start off with a video before you even start the lecture. So I'd like you to watch this crash course video. You can start at minute 340 when he starts talking about joints specifically. And again, this will talk about types of joints, but also illustrate the types of movements that each joint permits. The second video I'd like you to watch is in the ebook. Again, going into a little more detail on types of joints, examples, and the types of movements that they enable. So, what is a joint? A joint, or an articulation, is where two or more bones meet. Those two bones do not have to move, right? A joint is just where two or more bones meet. Those joints can be connected by bone. We call that a synostosis. Synostosis is usually an immovable joint when two bones come together and become a single bone. So, for example, an infant is born with right and left frontal and mandibular bones, but those fuse into the frontal bone and the mandible. Same idea, like the childhood ilium, ischium, and pubis bone all fuse together at synostoses, at bony joints to become one fused coxal bone. Joints can also be connected by cartilage. So for example, the costal cartilage allows our ribs to connect to the sternum. That's considered a type of joint because the bone is connected to the other bone via cartilage. Joints can also be connected by fibrous connective tissue. So in the case of our sutures, for example, that connect our parietal bones, we need fibrous connective tissue to keep them together. The biggest category of joints we'll discuss are called synovial joints. And synovial joints require accessory structures called tendons and ligaments for stabilization. We spoke about this before, but ligaments are bands of dense, regular connective tissue that connect bone to bone, whereas a tendon are ropes of connective tissue that connect bone to muscle. And both of them will come up a lot when we talk about the musculoskeletal system. And both ligaments and tendons are dense, regular connective tissue with many parallel fibers of collagen. And remember, that parallel structure allows a lot of strength, but also for motility. So, let's talk about different categories of joints, starting from the least mobile. So, an immovable joint is called a synarthrosis. Plural is synarthroses. And a good way to remember it is S, synarthroses, stay still. Those are like sutures. So bones are actually tightly joined by thin layers of fibrous connective tissue. Dense regular connective tissue, specifically. These are joints, technically, but it's made out of connective tissue. And they don't move. So this is an example of a joint that stays still. It's a synarthrosis. There's no movement at all. They just connect two bones. So therefore, it's technically a joint. So think about these when you think about the sutures of the cranial bones. Also, the epiphyseal plate, where the growth plate once was, is an example of an immovable joint because where two parts of bone meet. Other examples are synarthroses of the. Actually, I'll talk about this in a bit. But for good examples of a movable joint, know that sutures in the cranium is like a great example. We then have some slightly movable joints. We call these amphiarthroses. And this is where bones are separated by a little bit of cartilage. So there's cartilage in between these slightly movable joints. There's limited flexibility. So with this, you should think about the hyaline cartilage that makes up the costal cartilage, the cartilage that connects all the ribs to the sternum. Right, that's a joint, technically. Right, you're connecting the sternum with the rib. So what lies between that is a slightly movable joint called an amphiarthrosis. Another good example is in the pubic symphysis. There's a little bit of fibrocartilage in the pubic symphysis that's slightly movable. So this is called an amphiarthrosis. The fibrocartilage in the intervertebral discs is another example of slightly movable joints. Then we finally have the most movable, which are called diarthroses, and diarthroses are dynamic. When you think about joints, most of the time you're thinking about a diarthrosis. These are also called synovial joints, and they're called synovial joints for a reason you'll soon see. And these are the freely movable joints that are surrounded by an articular capsule. So let's look at this picture up here. You can see two bones that are meeting, but there's this capsule. Articular capsule is this whole thing over here. And inside the capsule, there is synovial fluid. So there's a synovial cavity with synovial fluid. So technically the two bones are not touching. They're separated by a slight space that's filled with synovial fluid that lubricates and nourishes the cartilage, which is at the end of each bone. So this cartilage is called articular cartilage. So the articular cartilage is at the end of each bone, right, at the epiphysis of each bone. And then you have synovial fluid contained within this capsule. So that's what we're looking at when we talk about diarthroses. There's another picture over here that shows that you have two bones. Each is lined with articular cartilage, and then this joint capsule basically keeps everything together. And inside you have synovial fluid that lubricates and nourishes the joint cartilage. So pause the video and see if you can answer this question. The answer is C, a synovial joint, aka diarthrosis. So some joints allow movement in many directions, and natural movements like walking or running are actually compound movements. It's multiple types of movements that involve multiple types of joints. And usually exercises that involve compound movements are more effective than single joint exercises. So if you have an option to do some kind of an exercise where you utilize multiple types of joints and different movements, that tends to be more effective. And physical therapy is a type of therapy that focuses on particular joints or particular muscle groups for rehabilitation. So just to define some things, the range of motion, that's the degrees through which a joint can move. And the range of motion is determined by many things. It's basically an assessment of how flexible a patient's joint is. Right, like how well do these joints perform? How is the range of motion? So it's determined by a lot of things. It's firstly determined by the structure of the articular surfaces. So depending on the actual bone structures, that will determine the range of motion. So for example, the elbow is a hinge joint, and it works because of the structure of the bones in the elbow. So the olecranon of the ulna fits into the olecranon fossa of the humerus. And because of the structural compatibility, this allows flexion at the elbow. Range of motion is also determined by the strength of the ligaments and the joint capsules themselves. So some people who have longer ligaments are falsely called double jointed. They still have the same amount of joints, but they have an increased range of motion because they have stretchier or longer ligaments. Finally, the act of the muscles and tendons themselves influence range of motion. If you don't have strong muscle tone, you won't be able to have the full range of motion on a certain joint. So the muscle tone, right, is also a factor of range of motion, which is the state of tension maintained in your resting muscles. So now we're going to talk about 6 different kinds of synovial joints. Most of them are, or not most of them, but some of them are just found in the hand mostly. But some of them you'll see all over the body. So this is a slide that I'd like you to keep on going back to that has the animations of the 6 different kinds of joints. I want you to understand the basics of how these move. And in class, I would have loved to illustrate this in person with some volunteers, but we'll try our best in this case. So let's talk about the first type of synovial joint, the first type of diarthrosis, a ball and socket joint. A ball and socket joint. And it's called a ball and socket because the smooth head of the bone fits within a cup-like socket. So in the example of a shoulder, we have the humerus, the head of the humerus fits very well into the glenoid cavity, right? It fits perfectly into the cavity that's made up by the scapula. So this allows for multi-axial rotation. You could rotate in multiple axes, right? You could try this right now. You can move your shoulder forward. You can move your shoulder back. You should be doing this now. You can move your shoulder to the right, and you can move it back towards your body. You can also rotate it. You can roll your shoulders around. Right, so everyone roll your shoulders around. That is a ball and socket joint. Same examples is found with the hip. So the acetabulum of the hip bone fits or allows the head of the femur to fit inside. And that's what allows you to roll your hips. So you can rotate your hips. That's a ball and socket joint. So you can see over here, you could rotate your hip outward. You could point your foot forward, or you could point your foot to the right. That's part of the ball and socket joint. And you can feel it in your hip. You can actually feel the ball and socket of your femur if you try to palpate. So now I'll talk about 2 other kinds of synovial joints. A saddle joint, that's a good example of the opposable thumb joint, the trapeziometacarpal joint. This is where both bones have a surface that's shaped like a saddle. That's why it's called a saddle joint. One is concave and one is convex, so they fit on each other. Now you should everyone try to oppose your thumb. That's a good example of a saddle joint. That's your trapeziometacarpal. This is your saddle joint example of your opposable thumb. We also have gliding joints, also known as plane joints, which is where you have flatter bones. This is a good example in the wrist and the ankle. These flatter bones slide past each other. They have some cartilage in between, so they don't slide too much and cause too much friction. So these are called plane joints because they have flat surfaces. The other ones are called saddle joints because they have saddle-shaped surfaces. So these joints are named based on the types of surfaces where the bones meet. Hinge joints, these are good examples of the elbow and the knee. It's where one bone fits into the other, where one has a convex depression. One has a convex surface and one has the concave depression. So that's shown over here at the knee. You can see the femur is articulating with the tibia here. And these are monoaxial. They only move freely in one plane. So everyone you can only kick your knee in one plane. You can't go side to side with your knee joint or your elbow. Within your fingers, you have hinge joints. So you can bend your finger because of like a hinge, but you can't rotate your finger to the left or right. Right? So it's monoaxial. It moves freely only in one plane. A pivot joint is one that spins on its longitudinal axis. So these are also monoaxial. They can only move in one dimension, in one plane. When you shake your head no, the atlantoaxial joint is an example of a pivot joint, right? When you're shaking your head no. That's rotation. Also, you have supination and pronation. So when you supinate, you're basically rotating, you're spinning your radius and your ulna along its longitudinal axis. So everyone, you should try to pronate and supinate. You should rotate your ulna and your radius front and back. That you're using your ulnar joint, that's a pivot. So 2 examples of a pivot joint. So the hand features multiple types of joints. So we can see over here, in between the phalanges, we have hinge joints, which allows us to flex our fingers. You also have, we said, the saddle joint is the trapeziometacarpal joint that allows opposition of the thumb. We have the gliding joints, or aka the plane joints of the carpal bones. So again, you see a lot of different kinds of bones just within the hand itself. One final type of joint I forgot to mention are condylar joints, and this is where you have an oval-shaped condyle of a bone that fits into a similarly shaped, like a socket of another bone. So it kind of looks like a ball and socket. It's like an oval and socket, but this only allows biaxial movement. Ball and socket allows for multi-axial movement in multiple planes. With condylar joints, you don't have that. In condylar joints, you still have some rotation in one plane. A good example of this are the metacarpal phalangeal joints, so the ones that are between your palm and your finger. So it kind of feels like you kind of feel that oval-shaped condyle, and you can move it in one direction and you can rotate it slightly in the other on that joint. Another example of a condylar joint is the TMJ, the temporomandibular joint, and that's when you open and close your jaw. I should do that now. If you zoomed in, there is a mandibular of your mandible. You know what that is now. The mandibular condyle is an oval-shaped part of the bone that fits into the socket of the temporal bone. So that's why it's called the temporomandibular joint. And that's an example of a condylar joint. So going back to the image of the hand, we can now put together, we have hinge joints. We have some saddle joint example for the opposable thumb. We have gliding / plane joints in the wrist. And we have some condyloid or condyle, condylar or epsiloid joints that are found in between the metacarpals and the phalanx. So we'll talk about some movements of synovial joints. This will be a lot easier, I think, if you watch a YouTube video watching people do these movements, if you don't feel comfortable looking at it in 2 dimensions. So a lot of these terms are presented in pairs with opposite meanings. So we're going to see there's like flexion and then there's extension. So you need to understand how these 2 paired meanings kind of what they mean to each other. You also have to understand anatomical planes, and you have to remember what anatomical position is. That's important. And zero position is the position of a joint when a person is in the standard anatomical position. So that's zero position, is anatomical position. What we do is we describe joint movements, how they deviate from the zero position, or how they return to the zero position. So we're going to describe these joint movements in that way. So I suggest watching an overview video. This guy comes up with some ways to remember these terms, and he talks about the planes and goes through all the different types of movements and shows you with great explanations. So I think this is a good starting point to understand a lot of these different movements. The link is down here. So let's dive right in. So first we'll talk about flexion and extension. And flexion is defined as a movement that decreases the joint angle. So if you started off with your arm down, you're going to decrease the angle if you flex, right? So a hinge joint, when you flex at the elbow, you're decreasing the angle, right, at your elbow. It's going from 180 degrees and it's decreasing. And after you flex, when you return your bone to the position, you return the joint toward zero position, that's called extension. So you have flexion and extension. So everyone flex at the elbow and then extend. If you were to go even behind your back, like reach behind your back, that's called hyperextension. So you extended the joint beyond the zero position. So again, everyone flex, then extend, and hyperextend. Right, same idea as in the hand. You can flex, you could extend, or you can hyperextend. So flexion and extension occur at nearly all diarthroses. Hyperextension is limited to only a few types of diarthroses, like a hinge joint. So again, here's flexion, extension, and hyperextension. Here's a good example of, so she is flexing at the hip. So this hip joint over here started off in one angle, and then it decreased. Right, it went from 180 degrees straight, and then it became closer to midline, closer to the center of the body. So that decreased the angle. So this is hip flexion. Likewise, if she were to take her knee and try to move it posteriorly toward her thigh, that would be flexing at the knee, and the knee is a hinge joint. If she were to return her leg back to the ground, that's extending, right? It's returning toward zero position. So take a second to pause and make sure you understand these terms. We also now have abduction and adduction. And this, so abduction, it's movement of a body part in the frontal plane away from the midline of the body. So when you abduct, like a child abduction is taking away, that's how you can remember the movement of a body part away from the midline of the body. So you can abduct your arms right now. You move your body part, you move your arms away from the midline of your body. Hyperabduction would be to raise your arm over your back or over the front of your head. Adduction is when you move back toward the midline in the frontal plane. So again, everyone abduct your arms and now adduct them. Hyperadduction would be like crossing your fingers or crossing your ankles. So you're moving them so toward midline, you're actually crossing them over the midline. So you can also abduct your fingers by spreading them apart. So everyone abduct your fingers, and then you can adduct them by putting them back together. And then if you cross your fingers, that's hyperadducting. It's crossing your fingers. Next, we have elevation and depression. So again, we're in the frontal plane, and elevation is when you raise a body part vertically. Depression is when you lower that body part in the same plane. So you can depress or elevate the shoulders. So everyone elevate your shoulders. You're moving the shoulders vertically, and now depress your shoulders. Protraction and retraction refers to the anterior movement of a body part in the transverse plane. So now we're talking about the transverse plane, not the frontal plane. So when you protract, you're moving a body part forward. So you can protract your shoulder by pushing it forward. You could retract your shoulder by pushing it back. You're going front to back, anterior to posterior. So you can retract your shoulder or protract your shoulder, as shown here. So you can elevate, depress, protract, or retract the shoulder. You can also protract or retract the jaw, right? By pushing it anteriorly, the mandible is protracting. And when you pull it back, right, you're retracting the mandible. Circumduction is when one end of an appendage remains stationary while the other makes a circular motion. So a good example is like when an artist is making a circle on a canvas. So everyone should pretend like you're making a circle on a canvas. What you're doing is you're circumducting your upper limbs. All right, that's circumduction. Your shoulder is anchoring your arm, right, your appendage. But yet the other end, the distal end, is making a circular motion. That's circumduction. Rotation is when a bone spins on its longitudinal axis. So longitudinal axis means the long axis. So think about the upper arm or the lower leg or the whole leg. It's when you rotate a bone on its longitudinal axis. So because of our shoulder, because of the ball and socket joint, we can rotate our upper limb. And there's two types of rotation. If you move your bone inward toward the midline, that's called medial or internal rotation. Whereas if you move the bone outward, that's called lateral or external rotation. So everyone rotate your arm medially and then rotate it laterally. We finally have, or almost finally, supination and pronation. This refers mostly to the antebrachium. These are forearm movements. Supination is when your forearm moves your palm to face up. So when you are supine, your palm is facing up. So everyone try to move your forearm. You're moving it at the elbow. And your bones are actually parallel to each other in the supine position. So in anatomical position, we have the radius outward, right? It's the radius, and then the ulna is more medial. So supination is when your forearm movement is turning your palm to face up. Right? The forearm is supinated in anatomical position. When you pronate, that means you're moving your forearm to turn your palm downward or posteriorly. And in the pronated state, your ulna and your radius actually cross over. They actually make like an X with each other. And you can feel that a little bit when you try to pronate. So that's an example of supination and pronation. And now you should look back and think about what type of joint allows for supination and pronation. So we should be able to look back and answer that type of question. So we also have special movements of the head and trunk. You can flex at the waist, right? So you can bend forward. That's called flexion at the waist. Again, you're decreasing the angle by bending forward. And if you were to move back toward anatomical position, that would be extending when you straighten your trunk. If you were to bend backward, that's hyperextending, when you literally bend over backwards. Lateral flexion is when you tilt your trunk to the right or to the left. So you're flexing, you're decreasing the angle, but it's laterally, side to side. So we spoke about this already, protraction and retraction, elevation and depression, but we also can have special movements of the mandible that are called excursion. So excursion is when you move your joint right or left. At the TMJ, you're moving your mandible right or left, away from the zero position. When you're doing medial excursion, you're moving back to the zero position, back to midline. So this is medial excursion. This is lateral excursion. We spoke about protraction and retraction and elevation and depression. When we grind side to side, we're doing medial excursion. So these are not as important. I mentioned some of these examples already. Radial flexion is when you tilt your hand toward the thumb, toward the radius. So everyone do radial flexion. Tilt your hand toward the thumb. You also have ulnar flexion when you tilt your hand towards your little finger, toward the ulna. You can abduct your fingers by spreading them apart. You can adduct them by bringing them together. We said you can hyperadduct them by crossing them over. You can flex your fingers by curling them. Those are hinge joints. And then you can extend them by straightening them again. So again, I would really take the time to make sure you understand each and every movement. Being able to do them yourself is the best test to see if you understand them. Lastly, we'll talk about the foot. You can have dorsiflexion. So dorsiflexion is when you elevate your toes upward. So this is zero position here. When you dorsiflect, think about dorsal like back. You're elevating your toes back. So like when you take a step up, you're dorsiflecting. The opposite of that is plantar flexion. Plantar flexion is like when you're tippy toe. You're pointing your foot downward. You're extending the foot so your toes point downward, just like a ballerina point. That's called plantar flexion. If you move your if you move your sole medially, that's called inversion. So when you turn your soles inward, that's called inversion. And when you move your soles outward, laterally, that's called eversion. So with the foot, you have dorsiflexion and plantar flexion, inversion and eversion. Okay, so we still have more. I thought that was the end of it. These are less common. The palmar abduction of the thumb is when you move your thumb away from your hand to point it outward. Like to point it forward. So when you're holding when you push your arm, when you move your thumb forward, away from the hand, you're abducting, right, the thumb. When you move your thumb away from your index finger, that's called radial abduction. You're not going to be tested on these specific ones. Flexion of the thumb. Of course, you could flex your thumb. And you could extend your thumb when you straighten it, right? Because you're decreasing the angle of that joint. Think about what kind of joint that is. What kind of joint allows for opposition of the thumb, right? Opposition is when you move the thumb to touch the tip of any of your other fingers, right? We can oppose our thumbs. That's something unique to primates. And that's, again, a special movement of the thumb. And reposition is when you return the thumb to the zero position. So that's the end of most of the joints, most of the general types of joints. We'll dive a little deeper into the specific names of joints when we talk about the muscular system and when we tie it all together after chapter 11. So arthritis is a common joint disorder that refers to when a joint is inflamed. You can have osteoarthritis. That's chronic inflammation or injury that leads to the damaging of cartilage in the joint. So a lot of times the articular cartilage of a joint gets inflamed because of injury or some other kind of disorder that leads to inflammation, and that causes osteoarthritis. There's also rheumatoid arthritis, which is an autoimmune disease where your connective tissue and your joints are actually attacked by your immune system. So you generate antibodies against the connective tissue that allows your joints to work properly, and that gives you, again, inflammation of the joint, which inhibits the full range of motion. A sprain is when a joint is forced past its range of motion without being dislocated. So a sprain is not a dislocation. Ligaments are injured in a sprain. So ligaments are injured in a sprain. The old advice used to be RICE, right? You put rest, ice, compression, and elevation. Now we don't know about the resting or the ice part, actually. Now we know that it's good to move around your joints a little bit as tolerated. Ice, we're not that sure about. It may not improve healing in the long run. And what it does do is it reduces immediate pain by numbing it, and it might lower the swelling from the joint injury. So we don't really know, but compression and elevation is still recommended. But resting is not, it's still a little up for debate. how much you should rest your joints in recovery. But that's up for a professional to decide, not your professor. When you do dislocate a joint, that's when your bones no longer line up properly. So this is showing a dislocated shoulder. So that's the joint is moved past its range of motion, but the bones no longer line up properly. And in order to fix that, the joint must be relocated by a physician. So that's the end of the material from Chapter 9 on the exam. So it's rather short. I definitely want you focusing more on Chapters 10, 11 for the exam. So this is the least important chapter, I would say. But I have some information on lower back pain might be helpful for some people. These are some book recommendations. As far as lower back pain goes, it's an example of something we don't know too much about. And a lot of times we suffer from lower back pain and not knowing what causes it. So lower back pain is not a joint disorder. It's often a type of muscle disorder or muscle trauma where the muscles are too tight or too weak or too imbalanced. But there are some literature out there, some theories that indicate that psychological trauma can impact the body. And of course, this is referred to as psychosomatic or mind-body. That's literally what psychosomatic means, is mind-body. There's some books that talk about healing back pain that are, I've heard personally, were very helpful in understanding the psychological aspect of some of these physical disorders. So here's some more information about orthopedics, which is just the branch of medicine that specializes in the skeletal system. There's different types of fractures. So if you're interested, you could study different types of fractures, but I won't test you on this. And when bones do get fractured, they need several weeks to heal. And the end must be touching, so the bones often have to be set or reduced in order for the natural healing to take place. That's why we give casts. So a cast would provide support and prevent any re-injury while the bones are going through their normal healing process. So these are the stages of bone repair. What first happens is a hematoma forms, so a large blood clot forms, and blood is released from the blood vessels that were damaged from the bone break, from the fracture. So that basically causes everything to clot and prevent any external bleeding. You then have cartilage start forming. It's called the callus. This takes up to a month to occur. So between the two ends of the bone, you start having some callus formation of cartilage. And it also forms a collar around the break. It's kind of like gluing it again together. And after about 4 weeks, you start ossification. So the cartilage becomes bone again. You start getting blood vessels penetrate through the bone, through that ossified bone. It's still spongy bone. But then the next step is the remodeling process. So the spongy bone finally gets remodeled, where you have a good medullary cavity like you should, and you have the compact bone around the cortex. And this, again, could take up to 12 weeks for a full bone repair. Herniated disc is also another common disorder that's technically a joint. And that's where the intervertebral discs protrude beyond the vertebrae. So this might apply pressure to the nerves, which causes intense pain. And then when your muscles are weak, or your posture is unbalanced, you just continue to put more and more strain on your discs. And this might have to be surgically intervened with. So that is the end of Chapter 9. There's a lot more information in the book, but I think this is a good starting point, especially because Chapter 10 and 11 is rather dense. So this should be fully understood and comprehended before moving forward. If you have any specific questions, please feel free to email me. And if you have any trouble hearing or seeing any of these images, please let me know. I will try to work something out. I hope you enjoyed that lecture, and I will see you soon for Chapter 10.